Waukesha Board of Education to order. Verification the meeting was properly posted.
Yes, it was.
Excellent. Thank you very much. Next up is opportunity for citizens to speak. Seeing nobody, we're moving on to add the action items for the evening. First action item is approval of October 12th, 2020 minutes.
I so move.
Thank you, Mrs. Voigt. Is there a second?
I'll second.
Thank you, Corey. Any discussion? Questions, concerns, corrections? Seeing none, all those in favor say aye. Aye.
Aye.
Opposed? There you go. All righty. Moving on, approval of the vouchers.
No questions.
No questions?
Nope.
No? You got me a little crazy over here, sitting over there. Usually sitting over here.
Yeah.
Okay.
Well, she didn't want Joe peeking over her shoulder all the time.
Okay, well, no, I wouldn't either. Seeing what she's doing, watching her computer. Alrighty, so are there any questions that might have come up since? No?
No.
No? Looking for a motion?
I'll move to approve the vouchers for November 9th, 2020 as presented.
Montiel, is there a second? Ranchek? All those in favor say aye. Aye.
Aye.
Opposed? 5-0, perfect. Alrighty. That concludes our action items. Now we're up to discussion information items. First one up is referendum financing plan review.
Yeah, can you go get Michelle? Michelle Weiberg's here from, and I have our speakers coming in one at a time, just in case you're wondering what we're doing. Michelle's here tonight just to kind of update the Finance Committee on, if you recall, as part of our levy approval, it included defeasing $5.1 million towards the referendum approved debt. So I thought it was important for you to see what we're going to do with the money and what's the impact of that, and then we can talk a little bit about what the future might hold. So in your packet, you have a summary sheet of some of the key points and then a couple of costings that Michelle will walk us through, and then we can answer any questions you might have on this topic. So
Great. Thank you. Good evening, everyone. We want to just first maybe recap the goals that we talked about pre-referendum. So the actual interest rates as a result of the financings that have been completed were far lower than what was projected pre-referendum. So we had a two-phased financing plan. We projected that the first phase pre-referendum, the interest rate at 3.25% and the second phase at 3.5%. The actual rates were 2.08% on the first phase and 2.1% on the second phase. And we did these two phases. We did the first phase as a traditional municipal market issue, and we did the second phase as a bank financing to give us prepayment flexibility. And the reason being, and we talked about this throughout the entire referendum process, is we wanted to make sure the district had flexibility if you found yourself in a situation where the operating mill rate was going down, to levy additional dollars to prepay this referendum debt. And that's exactly what you are able to do this year. So this plan is kind of, as they said on the A-team, I love it when a plan comes together. This is really unfolding exactly how we had kind of anticipated it would be. The lower interest rates had resulted in certainly a lower tax impact. When we look at the table on this first page, pre-referendum using those interest rates, the total interest cost would have been about $10.9 million with an average tax impact of 72 cents and the debt to be repaid over 10 years. The base scenario, that was after we finished the financings, that's if there were no prepayments. We already know that interest costs would be reduced to $6 million, and the tax impact down to 62 cents, and again, the repayment over 10 years. But as we get into prepay debt, as you would be doing this first year in 2021, we already know just with the anticipated prepayment using additional levy dollars this year that will reduce that interest cost down to under $5.2 million. The tax impact stays approximately the same, but you're repaying the debt over an 8-year period versus 10 years. So just with 1 year of prepayment, as is you're able to do with this year's levy. You've shortened the debt by 2 years, and you're reducing interest cost by over $800,000. At that point, after you do this repayment in 2021, all of the debt repaid through that point would represent 36% of the total principal that was borrowed. So you are, paying off this issue at a very fast pace, which is great news, reducing interest costs and reducing the overall term of the debt. So that's a broad brush overview of what your the methodology is and the process is. When we get into the two financing plans, I'm not sure what order you have these in your packet. The yellow first? Okay. That makes sense. So the first plan, what you're looking at is just what you would be prepaying. So we have inside the box the two referendum phases of financing that I just spoke about, $45 million as a traditional municipal market issue, $15 million as a bank loan. That bank loan is prepayable at any time. So you would use excess levy dollars available with this levy that was just set of over $5 million to start prepaying that bank loan. As a result, you're shortening up that bank loan by at least 2 years. So you can see the reduction in principal payments kind of working from the bottom up. So you prepay the last maturity, the second last maturity, and a portion of what would be the 2027 maturity. So shortening the life of the debt, reducing interest costs, as I spoke of on the previous page, and just reducing the overall financing costs. We were asked by administration to say, what if this continues? What if we are able to keep prepaying at approximately $5 million a year? So all the next page does is just illustrates what that would look like. So you're prepaying $5,150,000 this year. If you were to have an additional $5 million available in the next 3 years, you would be practically debt-free at that time. So essentially, the example additional levy column, you see $5,150,000, then you see $5 million for 3 years, and then you see $1,037,000 in 2025. That would essentially be the last year you would levy for debt. So this debt could be shortened as much as, down to a last payment in 2025, so a 6-year overall financing if you were able to kind of continue the process that you're doing right now in prepaying debt. At that point, you would have prepaid not only that entire bank loan, but also the promissory notes that were outstanding as well. So I'm sure Darren can speak to this better than I, but this is really just in keeping with the plan that was discussed throughout the referendum process and throughout the financing process as well. This ability to prepay debt, shorten the term of the debt, reduce interest cost, if available with the levy, while still maintaining a tax rate that is, at or lower than what you were at pre-referendum.
The flip side of this approach, and one we've talked about, is someone making the argument, well, you're taxing more than our debt schedule would call out for. And so we try to strike a balance, and as we've talked about, this is an annual decision. This isn't something that we have you sign off on $5 million every year for the next 5 years. It doesn't work that way. But at your table on this chart is the final Waukesha County total tax rates. For K-12 school districts, I didn't get into Arrowhead and all the feeder districts and all that. But even with this defeasance, we have the second lowest tax rate in Waukesha County for K-12 schools. McWanago's at $8, and we're at $8.03. So I think we're able, and I think we are striking that balance, providing one of the lowest tax rates available or out there, and still saving $810,000 in true savings to taxpayers, because we will never levy a cost we don't have, and we don't have the authority to use that levy for other purposes. So I think between the savings and this low tax rate, I can't promise this every year, but any other questions? Like Michelle said, it's kind of coming together like we had envisioned it. Not all this is great news. Having a very flat or declining revenue limit on the operational side certainly helps out, so this isn't all financial wizardry by any stretch. But you might as well take advantage of the cards you're dealt, so.
Questions?
Just a quick comment. I know we talked about this quite a bit, but thank you. Choosing to get a bank note that has prepayment options is fantastic. I know you guys plan for these types of things, but when I think you and Dr. Cook and Dr. Gray toured the schools and gave this presentation, I know there was hope that we could do this, if I remember correctly. But being a skeptic, there's no way we're going to be able to do that. And you always hear the horror stories about referendums. We estimate the best we can, and they come in higher, but this is the exact opposite. So you're spending money. I think the taxpayers already knew that would come out. They already approved it, and we're spending money to save them money. So for my chair, it's a great opportunity. Hopefully it can continue, but we'll see.
Franchek.
Yeah, and I just wanted to say a kudos to Darren, because the only spot that's ahead of us is McQuantico, and I believe we took you from McQuantico. So I think
Or
of-
save me, however you want. Just kidding,
think,
McGuanic, I love you.
I think seeing us in second place, you had a lot to do with getting them into first place. So I think we'll beat them soon.
I was tempted this year, but I thought the defeasance was better use.
But yeah, it looks like you have a lot to do with the first two schools being in the position that they are.
All right. Thanks much.
Thank you.
Up next is the Employee Health Clinic Services presentation. Oh, boy. Oh, boy.
Where, there's one by Sherry, and hey, if you want to take that last chair there. And we have Joe virtually, so we're trying to keep him.
Yeah, stay away from him. Yes.
On.
Yes, I do.
Thank you very much.
Thanks.
So, we've been talking for the last, pretty much all of 2020 about the clinic, the employee health clinic, and under the working knowledge that that agreement is coming to an end at the end of 2021, and the desire to look at options for the board to consider on how we move forward, whether it's with the existing clinic, with our existing partnership with the county and city, and then do some due diligence to pursue other ideas that may be out there. So in June or July, I can't remember when, Jeff, we kind of gave you, was it July, the results of the RFI, and those page here, it's a recap of where we were financially, and it looked viable in terms of services and certainly the numbers. But tonight we have ProHealth here to actually walk through. They had the most, Aurora and ProHealth both put in very strong proposals along with some other firms, but when you blended the financial with the level of services and things that they could bring to the table, we felt ProHealth was the best one to move forward with as we investigate how to roll this out. So keep in mind, we don't have a specific plan. I'm not here to say we have $6 doctors at 2 sites and all of that yet. But the baseline data certainly shows that this is something we should continue to look into, and we'll walk through decisions that you'll have to be making as we go forward. So Jeff and I will kind of recap very quickly the presentation we gave you in July with a couple of tweaks. It's only 6 slides, and then we'll turn it over to ProHealth and let them walk you through. And this is the complete PowerPoint you have that was just handed out to you. So Jeff, if you just want to walk us through these and then tell me when to forward, that'd be.
Okay. Good evening, everybody. Good to be back with you. During our RFI, we wanted to determine how we could improve access and overall service, and to determine, really, we're just raising these questions. And so what we determined was that instead of one clinic location, we could have multiple clinic locations. We can have a variety of different services at each location. Local providers would be providing the virtual visits. There would be a lot of flex in the scheduling based on our employee needs. There would be a scale up or a scale back opportunity. So it's not quite as rigid as one size fits all. And because of the manner in which the staffing works, the potential interruptions in care from having one provider as in the clinic is somewhat eliminated. So from an access standpoint, we really wanted to vet that out and found that, yes, access could be improved. So next one. The next key deliverable during the RFI was, is there a way that technology can be leveraged in a better way to derive a better health outcome for your employees, and thus ultimately lower healthcare costs? And so we determined that, yes, there were ways to do that. I would say the key to that is the utilization of what we call the electronic medical record, which is EPIC, that most healthcare systems use, that would interface with the ProHealth clinics. So even employees who would have HRA and biometric screenings would actually have that data input into their electronic health record, which doesn't happen today. And any doctor they see virtually at any system in southeastern Wisconsin would have access to that information. So leveraging technology, you've got MyChart, you've got scheduling virtually, text reminders, and good reporting, all that there. So that's technology. The third thing was, is there a way to lower cost? Yep, you were good, Darren. There we go. So can we improve access? Can we leverage technology? And can we lower costs? And I guess just to back up to say that when the clinic was put into place 7 or 8 years ago, it was a different marketplace. Healthcare is a very dynamic marketplace today, and there's rapid changes, especially as a result of COVID, from a deliverable standpoint, healthcare system. So we're just talking about taking the clinic concept to the next level here. So it was a good decision when you made it a while back. Things have changed. We can improve access, we can leverage technology, and we can reduce cost fairly significantly, even if we have multiple locations. There are no capital costs, which is a big deal to the district, and much less administrative involvement in terms of Kay and Darren's time and their team as well. The one footnote that Darren and I and Kay would make to this is the estimated cost. There are some expenses currently in the costs for the clinic for prescription drugs, but those are really de minimis as a percent. It's not even 10% of the overall cost. So those would be outside of this, but I just want to footnote that. But overall, improved access, leveraging technology to a better healthcare outcome, and lower costs can be delivered pretty substantially. So the next question is, okay, what decisions do you need to make? And the decisions that we're asking you to make is whether or not district should participate in the upcoming request for proposal with the existing partners in the intergovernmental agreement between the city and the county. And that will be centered around the current clinic site and mode of operation. And that RFP will be constructed and start probably in January of 2021. Or should we say, you know what, give our partners the courtesy of saying, we are not participating in that. You go do what you need to do. Our objectives seem to be satisfied based on the work that we're doing, and we're going to go down a different path.
Yeah, this is one thing we've tried to do throughout this process. We informed the partners back in February that we thought we needed to do some due diligence because healthcare had changed since the clinic had started. And so we've been sharing data with them. We asked them to be partners in this conversation. They've opted out as of now, but we've shared every report, every response to the RFIs. So the reason that this decision we're looking for it to be made in December, as I mentioned before, we don't have a specific plan for ProHealth and what this will look like yet because we have all of 2021 to figure that out. The decision's really being driven, and you're not bound by this as a board. We have no obligation. Besides, I think in terms of being a good partner, I think we need to let the city and county know if we're really not in the RFP, then let's not be part of the RFP because it could change the outcome for them. And that work needs to start in January. And I've, with as much authority as I have, I've said we'll try to make a decision in December to see how we go forward as a school district. But this is really the crux of it. Coming back in December is just choosing the path. So keep that in mind. So here's the upcoming meetings on the 7th. Well, the board meets Wednesday, but in December, we'll probably come back to FNF with any follow-up questions or something maybe we can't answer tonight. And then on December 9th, I haven't crafted what the motion really is at this point because you're not approving anything. We have no agreement with anybody to switch to anything. It's really choosing the path, and we can talk about what form that takes in the form of a motion or board decision. And again, the health stat and the clinic run through December 31st of 2021, just to keep that date in mind. So that's where we are. One other thing I'd like to add is this due diligence that we're going through is not a reflection on the partnership with the city and county. That has not ever been the issue. It's really a cost and efficiency and where are we with the existing clinic in the realm of where healthcare is now. So I don't want you to look at it in any different light than that. So with that, we have Pete and Vicki, and I'll switch over to the ProHealth slideshow. If you guys want to start by introducing yourself, unless you had questions on the numbers we were looking at, we can hit on that first.
Franchek?
I just, of the reminder, are you saying that whatever we do within the next year, we're still going to be where we are? If we did make a switch, it would be
Right now, we're signed through 2021. Mm-hmm.
Thank you. If we decide to not be part of the RFP process with the county and the city, and then pursue this track solely, but then that track doesn't work out and the board says, no, we're not doing an alternative model, are we still able to go back and be part of the existing model without not being involved in RFPs?
I don't know if it could be that clean.
Okay.
Or that flexible for us. I mean, it would be up to the partners. But they are also going to design a staffing and an RFP model around their participation levels. Bring us back, which I don't know, are we the largest or the second largest? Us and the county are the two biggest partners, so we'd be bringing back a large group of people. So I'm not going to say we couldn't do it, but I'm not going to promise you that we necessarily could.
So and that decision has to be made by the board, you're proposing December to either go part of the RFP process or not, or?
If we feel the need to let our partners know what we're thinking, I would say yes.
That's them, okay.
You're not legally bound or contractually bound to make that determination. It's more being a good partner, I guess.
Okay. And the the items that were presented, the cost savings at 3 sites and something else, that's anticipated, obviously, but it's not guaranteed. I know they can't. Do we know when would we know, I don't know who to ask this question to, what the downside would be to a change as far as our participants? Because right now, I'm guessing since we don't have 100% clarity, which we wouldn't at this point, how do we know, do you have a rough estimate when we may be able to assess that?
Well, I think the cost estimates are pretty sound, and I don't want to speak for ProHealth.
The services I'm talking about.
The services, I guess that's why Vicki and Pete are here tonight, is to talk about, ProHealth's probably our largest provider on our normal health plan. So I think there's a large body of work that's out there. Now, has it come in this form as a clinic and all that? No, but in terms of office visits and those types of things, I think ProHealth can stand by their reputation in the county. Just so you know what numbers you're looking at here, the 1.1 million is our budget, our share of the budget for the health clinic for, we're running on the calendar year because our 2 partners' fiscal year is the calendar year, so that's where we are. So that's for 2020. And then the estimated costs are derived from ProHealth's response to the RFI, just so you know where we pulled these from.
Yeah, that's absolutely fantastic. I love that. I think anybody would. Okay, thank you.
Other questions on, and we can come back to this as well. All right,
Sure.
Vic, if you want to introduce yourself, and I'll
Sure.
switch over.
So my name is Pete Bacon. I'm Chief Integration Officer of ProHealth Care. I'm on my 7th year. I'm a rookie compared to Vicki. I'm going to let her do a quick introduction.
Sure.
Well, I'll kick it off, and then she's going to do the bulk of it. She will, her team will certainly be running the show for us if we're fortunate enough to be able to strike a deal with the school district.
So I'm Vicki Dahlman-Papke. I'm the Vice President of Population Health Management and Employer Services. I've been with ProHealth Care for 30-plus years, a registered nurse by background, and love working with populations in the community and in our employers. So I'll get this all kicked off. Pete, you want to
Sure.
give us a quick intro?
Absolutely. Well, once again, thank you for taking the time today and giving us the opportunity. We have been working closely with the brokers and the administration. We're very excited about this opportunity. And what Jeff and Darren have said, healthcare has changed so much just in the last 3 months versus 7 years ago. And boy, we've certainly made some investments that I think are really going to shine very, very, very well tonight. Your team was very clear on what the objectives were. Jeff went through them about increasing access, leveraging technology and really looking at cost. But one of the things we really want to spend a lot of time today is on the patient experience. And that's something that, ProHealth Care, that's near and dear to our heart. We've made significant investments in technology and people to make sure that people can access health and health during this year. Healthcare, how do they want to see it, when they want to see it, and those things have made major changes here in the last few years. A couple things real quickly before I kick it off to Vicki. Just recently, we achieved 5 stars on Facebook. So that's our patients going out to rate ProHealth Care, and that's something that we're extremely, extremely proud of. A couple other things that I think you're going to see is, hopefully you'll see that we're a great partner. I mean, obviously our reputation in the community, I think, has been very well received. And the other thing is we're very transparent. We do everything we can. Darren and Jeff and others, anytime they've asked us for something, we want this to be very transparent. We think it's something that we can really provide for the community. We are part of this community. We've been here more than 100 years, and we really want to help you folks get a good lid on those healthcare costs. So with that, I'm going to turn it over to Vicki.
Yeah, I'm going to spend about 2 minutes going through ProHealth Care. Many of you know ProHealth Care. As Pete said, been in the area for about 100 years. But ProHealth Care, local health system, obviously in tune with the community, very quality driven, very patient experience driven. We have about 400,000 lives in this area. I'm not going to read through these slides. You've seen them. We're a large employer ourselves. We apply some of these methodologies to our employees first before we go out and talk to others about that. We have facilities across the community and here locally, right here in Waukesha, we have Waukesha Memorial Hospital and many clinics. The one thing that I did want to talk about is the continuum of care. Anywhere an individual is accessing us, whether that's from the home or the PCP office or an employer clinic, all the way through palliative care. So we truly have a continuity of health all the way through the lifespan of our patient or your employee. We wanted to spend a ton of time on our proposal and the patient experience. So as we move forward, as we've kicked this off, we really studied your data, really tried to understand where your employees lived and where they worked so that we could select clinics strategically around that accessibility. And the team came to our Brookfield Clinic, our Mukwonago Clinic, and our Waukesha Clinic. You have a constituency in Oconomowoc, but the three that they've chosen, I think will serve the bulk of your employees
And one thing on
their
that,
folks.
it doesn't have to be 3, it doesn't have to be 2, it doesn't have to be 1.
Mm-hmm.
You know, you want to pick a group of clinics that are going to, provide that access. Because if you have one site, a lot of people are not going to come in, to just that one site. But if you spread this out, we call it a distributed model, there's other places that they can go for care. And we can adjust that as time goes on, too.
And we spoke to the team and provided some information, written information about sample hours that could be custom to the school and your employees and beneficiaries. We believe both in the primary care and episodic care and urgent care. So in-person or virtual visits, as folks know, digital visits are the wave of the future. We went from 0 to 1 million. I mean, it was just amazing with COVID and how that has worked out for us and our patients.
And one of the things, we had already made that investment in there, thinking this was going to be 3 to 5 years. I mean, Vicki had 170 appointments today just virtually.
Yeah.
And, people are getting accustomed to it. I worked for a company called Teladoc, which is the largest telemedicine company in the country. We do 3,000 in a month. They're doing 300,000 in a month now. So people want to do that. And I don't know about you, but I remember when we had, my son would always get ear infections. It always happened on a Sunday afternoon. Urgent cares weren't open. We'd have to get in to see our pediatrician on a Monday morning. Then it's 24 hours, get the, antibiotic in them, and lo and behold, you and your wife have spent a day and a half away. Mm-hmm. Now with this, you have options to hit these virtual care places, and then you start the whole process a lot quicker.
Mm-hmm. So offering that in-person and virtual option, as well as the lifespan of your employees, employee health and occupational medicine. That includes pre-placement, drug screening, onboarding, FMLA, short-term disability, work comp, et cetera. And then wellness programming, the HRA, wellness and well-being programming that will all be placed into EPIC. And then we did have a indication about physical therapy because you do have that at your current clinical site, and we have that availability as well. As we continue our proposal, the team talked about custom communications and promotions to all members during the transition and all the way ongoing messaging to your constituency, and I'll talk a little bit later about that in our PowerPoint. But we wanted to point out ProHealth Care has stellar cost and quality performance. You're with UHC, premium designation. We are totally aware, as you probably are as well, that ProHealth Care is a distinguished provider in that area. I work with UHC every week. I meet with them every Thursday at 1 o'clock, both on our commercial plan and Medicare plan.
That's a lot of fun for her, by the way.
And we work on quality and experience and utilization. And we really want to be top box in this community. And we strive to have 5 stars, and we are very close. We were 4.95 stars last year out of 5.
One other thing on the premium designation, I know that, the health stats, the others go, well, why would you have a health system come in? They're just going to send all the business to their providers. The one thing that we made a commitment to is any one of that goes through these clinics, and we will only refer to Tier 1 premium designation providers, whether it's at ProHealth Care or outside of ProHealth Care. And in order to get the premium designation, you have to both have high tier quality and cost. And so, traditionally they want about 38% of the providers in the community being in Tier 1. We were 70% last year. We're in the 60% this year. We've been either number 1 or number 2 from the get-go. So that's our commitment to you, that we're only going to send them to those Tier 1 providers.
Just a quick refresher, can we touch on what premium designation?
Yeah.
What that is and how it becomes, how you're identified as a doctor in that category?
Sure. So the premium designation with United Healthcare is a select group of physicians who have met strict quality and cost criteria so that they would be considered the highest value. So the combination of quality and cost creates value. And it's not everybody in the United Healthcare network. So those folks are designated, and we are, by our plan design, trying to drive our employees to those providers because why? Lower healthcare costs are a trailing indicator of high value. And so what Vicki and Pete are saying is there's a large density high percentage of ProHealth providers who are premium designation. So to Pete's point, and I think we said this last time, but it's worth repeating. One of the knocks on systems running clinics for employees would be the health stats and their competition would say, well, that's just a mechanism by which they're going to get people through the door and constantly refer within their system. Well, 2 points about that specific, objection or question in this context. That is, number one, 70% of your care already goes to ProHealth. So, that's a sort of a moot point. If it goes to 72 or 74, it's really not, we're not talking about going from 40 to 70. That's number one. Number two is if they're premium designation providers, whether they're ProHealth or Aurora, we want them to go. And ProHealth has said, hey, we really don't have a horse in the race. We got a lot of your utilization right now. If your employee needs a referral to a premium designation provider, we don't have one, we're still going to refer it out of our system to a premium designation provider because that's what the district is committed to. So I think it's a real important distinctive of this opportunity.
We debated this, and I went back and forth because when I started, I was in that camp of, well, I don't want ProHealth in the clinic, and then they're just referring. But as I thought more through it, we're driving people to these providers in our main health plan. To me, we're just aligning our health plan with our clinic operation, and we've seen success with the premium designation doctors more than I thought we would recognize. So. Just so you know, some of our thinking, we did spend a lot of time on this specific topic. So
yeah, could I just add one more thing about premium designation? You say, okay, that's all great, and I'm sure some professors at Harvard understand what the cost difference is. Here's United Healthcare study would suggest that if all of our people would see premium designated providers, we'd see a 14 to 17% reduction in our overall cost. That's a big deal. So why are we suggesting premium designation providers should be referred to? It's because we're sort of chasing after roughly 15% lower healthcare costs because of the high value.
Corey?
Who makes that determination as what provider's a premium designation provider?
United Healthcare makes that designation based on their quality and cost metrics.
They got
Internally.
algorithms that they utilize, and they update them every year, and we get the information and we talk to them about it, but we've scored very well. I can tell you there's some other systems in the area that aren't necessarily happy. If 38% is their number in the community, and we're at 60s to 70s, it tells you a lot of other people are way below that 38%. And that's where the costs end up getting out of hand. And we're very proud of this program. This is a program that has really helped ProHealth Care grow somewhat because our numbers are so high. There's another school district in the county, and that's one thing they said. They couldn't believe how much business then shifted ProHealth Care because of what we've been able to do with it's actually the Tier 1 premium designation.
Is that something, I'm sorry, is this something we could point to as far as, I think, the promotion page where you say, look, these are the objective assessment of these providers. Maybe not.
United has, it's a little bit of a black box. It's an algorithm, but I'm sure we can look at something like that. But it is cost and it is quality. So you have to have a certain level of quality and you have to have a certain level of cost.
But we do educate, communicate that. Kay and her team on a constant basis with all the employees. Premium designation, premium designation, premium designation. Your employees understand what premium designation means, because they also have a financial advantage in the plan to see the premium designation providers. It costs them less.
That's the 14 to 17% you talked about?
Well, it costs the
Premium.
employee less to see a premium designation provider because we want them to go, because ultimately it will lead to lower costs for us. So we've got incentives built in the plan.
A trailing
They pay
indicator.
less, yeah, they pay less out of their pocket when they see premium designated providers.
Gotcha. Okay, thank you.
You bet.
As we continue with our proposal, we did talk a great deal about innovation in population health management, and that is really looking at the data and analytics and working together to improve the outcomes and the population health of your community. We do that all day, every day. That's one of my job descriptions, is to improve the health and well-being of our populations. And we really want to drive down the cost and improve the quality. Our financial arrangement that included both fixed costs for some of the services, as well as using your payer platform and activities around that. The patient experience, we wanted to offer convenient care options close to work and home. We talked briefly about that already, and that included the in-person care and virtual. But we wanted to offer, what we offer to a lot of our employers is the white glove golden ticket service. We just started that service less than a year ago, and it's been very instrumental in helping individuals navigate the health system, choose a PCP, get a visit, and stay connected. We know now through COVID, it's so critical to have a PCP and be connected to a health system. That navigation is critical, and we have individuals that work with those patients that are undoctored. Go ahead.
Just real quick, I mean, we have, it's a group of people that they'll interview the patient to find out where do you live, where do you work, do you want a male or female physician, do you want an internal medicine, do you want a primary care, we can do all that and try to get them in the right place.
And then our go ahead.
Microphone. You want me to repeat that? Okay, so one of the things that we do is, we want to make sure that we have a group of people that will interview the patient to find out where do they live, where do they work, they're looking for a male or female physician, are they, do they want internal medicine, do they want family practice, all those all go into that description and that discussion, and then they go ahead and give them options of who they might want to see. And as we all know, if you don't have a primary care, sometimes they're going to the ER for basic stuff, and you've got to just make those connections early on.
Mm-hmm.
So that's what we're doing here, and it seems to have worked extremely well.
Joe?
So is the patient initializing that contact, or are you also initializing that contact just to try and increase people to come, involved in the clinic?
Yeah, both. So we have a communication plan, Joe, that we want to put into place, but not everyone's going to react to that. So anytime we can make a contact with that patient, whether it's through the HRA or whatever, we find out that they don't have a primary care physician, then at that point we give them this golden ticket. At the same time, there's a referral put into the Epic system. The Epic system feeds that group of individuals that will interview. And if they don't hear from your employee or their spouse within a couple of days, they physically reach out to that person through a texting methodology to start, and then we'll reach out to them 3 times within a week to see if we can't make that connection with them. And so that's why it's so important that when we have those touch points, we take advantage of that and find out if they do or do not have a primary care, because that's going to save you in the long run.
Thank you.
Thank you. And then that continuous feedback loop, we have advanced over the last year and a half what we call texting. So anytime you have a service with us at ProHealth Care, you'll get a text message. It'll ask to rate the provider. It'll also ask to rate how the access was. Did you like your appointment time, et cetera. We also have the ability to get you quicker in the line if you want. So if your appointment is a little further out than you want, I had a preventive evaluation and it was 6 months out. I was happy with that, but they were able to get me in a month because there was a cancellation with my PCP, and I'm like, sure, I'll take that. And I just drove over and and got it taken care of. So that text survey after every visit is really critical to us.
Yeah.
And it allows us to really, if a customer or patient feels there's an issue, we can address it immediately.
Now, one other thing with that, this was something, we went with a company that had not fully built out that program. We thought it was so important that we wanted that instantaneous feedback. The way we survey our patients before, it'd be 6 weeks before we get feedback. So this is right when they leave the clinic, they get this note. So even the employees know that too, so it gives them more incentive to know, boy, I'm getting surveyed on everybody that's walking out of this clinic. And the beauty of that is, if the person doesn't score real well, we have someone that will intercede and talk to that person right away to find out what the issue was, so we can correct that on the spot, so you don't have people that are dissatisfied with their service. Our numbers are off the chart, and I think, once again, everybody knows they're going to get reviewed, and I think that's an important part to make them perform even better. So we've been very happy with what we've seen so far, and that has driven us to 5 stars, like I said, with Facebook.
We'll continue on because we really, sorry. Okay.
Thank you. I have experienced that text survey. It's very simple. It does happen, like you said, very quickly when your head's right in the moment. I also experienced, and I don't know if this is part of the system or not, that you'll be offering, is if you make an appointment and you want to get in as sooner than when you can get a text saying, hey, there's an appointment that's available sooner, would you like to take it?
Yeah, that's part of the program, and we all really enjoy that. And the nice thing about it doesn't leave holes in the provider schedule, so that frees up more time later to better match with volume. So that has been a very successful program. That was another thing that was very attractive to us, to put that technology into place.
So maybe one of the contrasts that you're seeing here is because of the way that ProHealth Care staffs these clinics, multiple clinics with multiple providers who are always there, that gives us, the district, flexibility to ask ProHealth, we want these time slots, we want this number of providers, these locations, because we're plugging into existing infrastructure as opposed to creating a custom fit for us and guessing what our utilization is and hoping the provider's not sick or something like that, or on vacation that week, or making sure they're staffed or anything else like that. So when we talk about care disruption or the quality of care, the consistency in this arrangement would seem to have be higher on an ongoing basis over time than what we might currently have today, simply because of the way that it's staffed.
Yeah, and to change the model to go to multiple sites, we're going to learn over time, right? We're going to see how the patient flow is, and we'll make adjustments. Now, we don't want to change every hour, every day, but whether a month later or whatever, we need to look at how we would staff it to be the most efficient. One thing you find out about caregivers, they want to help people. And if they're sitting on their hands, that's the worst thing for you, because you're wasting money for the school district, and they're wasting their time, which we are extremely busy. So we want to build a model that will flex to see what happens if you have 2 sites or 3 sites along with the virtual. And we'll keep looking at the algorithms to say, where do we need to staff this better? Where do we need to staff this less? And those will all be part of what we want to do ongoing.
Matthew.
So a participant, I think it's what you call, or patient, has a primary care physician, and this would get adopted hypothetically. Are they going to be able to keep that primary care physician?
Absolutely.
Okay. Because the
Absolutely.
white glove talks about people that
Yep.
don't have one, and then you'll
Yep.
assist them get one.
We
That's
will
what-
navigate the individual to a primary care physician.
Okay.
Can you hear me okay?
Yes.
And as individuals use the clinic, the employee clinic, we're not going to circumvent that arrangement, but we will work hand in glove. Our PCPs understand that these arrangements exist, and the providers in those clinics are part of the medical staff. They're part of the family. We work with one another. It's not, oh, that's my patient, or no, don't do that. We work together because we have one electronic health record. It speaks across the continuum, and these are all primary care individuals and credentialed to do the work that they need to with your constituency.
Okay. Thank you.
Yeah. The patient experience, I think we wanted to really hit this kind of hard, and I know you'll probably have questions because I think we wanted to kind of set ourselves apart from your current arrangement. We wanted to look at access, we wanted to look at technology, communication, et cetera. So we wanted to walk you through what an employee or a spouse or a child or dependent would have, the experience that they would have. So access, scheduling your appointment. Obviously phone. You can't hear me?
Oh, I can.
Okay.
I just have the slideshow when we talked last up, not, you've added the slides.
Yes.
Oh, okay.
So it's in your packet.
Yes.
And we are on page 10. So the patient experience. So access, scheduling your appointment. Phone, obviously, and then you'll get a text reminder that when your appointment is, and a MyChart notification. We really want our patients to be part of MyChart. And prior to COVID, Pete has some stats on our MyChart utilization. Do you want to repeat those?
In the low to mid 40%, and now we're in the 60% range.
Yeah.
And I'll tell you, we just had an upgrade over the weekend, and it is even cleaner and better than what it was. So a huge adoption. People are really starting to get it. I mean, think about it. The people, they can get access to the physician notes. They can schedule an appointment. They can request a prescription. They can send the provider a note. There's so many things. Their history's all right there. People are really starting to embrace this, and we're very excited about that.
Also, online verification and check-in prior to the appointment. We have kiosks as well in our clinics, so it's very fast and touchless. And in a COVID world, touchless is always good. Go
The
ahead.
text verification it might not seem big. I was so excited that we finally caught up with the dog groomers in the community, because we used to call people to ensure that they were coming to their appointment, because if you have open slots, that just really gets your schedule in a tough spot. This text verification or email verification has really made life a lot easier. It's helped us utilize our people in more effective ways than on the phone trying to call people to find out if they're going to show up for their appointment. And once again, if they don't want to come, they put no, and then it hits, like Joe said, it hits that list of everybody that said, I'd like to have an earlier appointment if one becomes available. That feeds it in there. The first one that takes that gets it, and then off we go. And then we can reschedule the person thereafter. So it works out. It's really improved a lot in our operations.
The visit itself, seeing the provider, face-to-face, virtual visit, or walk-in. The provider appointment, obviously, we're going to address all your issues, whether it's primary care, prevention, urgent care, et cetera. We're going to document that in Epic, and we're going to use MyChart for instructions, as well as give you a paper instruction and review those with you. What I think is critical is the after visit. It just doesn't stop there. There's ongoing communication that you will have with your provider. Obviously, that immediate text and that survey is important to us, but you can view the actual notes that your provider wrote. If you have questions about it, you can actually email them and say, I'm not sure what that means. Your test results will be there and populated. That after visit summary will be there, so you can refer back to it at any time. If you have an iPhone and you use the MyChart mobile when you're at the pharmacy, now what did that doc say? And you can show the pharmacist that information. Ask the provider a question at any time, and we answer those, and including a prescription refill or a change in prescription or question, and our providers are very good about responding. But also throughout the year, alerts, and those are digital in MyChart, and those are due or coming due prevention or test results, or tests that need to get done, whether that's primary prevention or chronic disease management. Say you're diabetic, you need a hemoglobin A1C, you need a women's health eval, you need a mammogram, you need a colonoscopy because you're over the age of 50. All of those alerts come through our system and remind the patient. That's our patient experience, and we really are very prideful about that patient experience. So it goes all the way through scheduling and all the way through the year, and that communication, I think, is key. Instead of that chasing your provider, you call the office, they try to call you back, it's always the wrong time. It's great when you can utilize the electronic methodology.
And if I would just create a contrast again between our current state and this proposal is, right now, we get a face-to-face visit with our current. Everything else is additive in this proposal, okay? Just again, to create the contrast.
And one other thing, just to talk about that, is everybody has a an electronic medical record. But if you're not attached to everybody else, you might as well have paper. I mean, in all honesty, once again, they talked about it before. Our system is viewed by Freighter, by Aurora, by Ascension, by Children's. And same thing is we can look at theirs. And so, if someone's in an emergency room downtown Milwaukee at St. Mary's, they can see exactly what's going on with the case of this patient. That's such an advantage. And you know what? It's not inexpensive for us to do that. But it's the right thing to do, and it really helps patients live because they can see exactly what that patient's been going through versus starting over from scratch.
And Vicki or Pete, can you walk us through what does it look like? And let's say we have just one clinic in Waukesha, just for the simplicity. Right now, people go to our clinic and it says Employee Health Clinic. There's a big sign. What's their experience walking into the clinic? Are they calling just the number and then just going to a office? Just so people are getting a full picture of what we'll be transitioning to.
Sure. So you choose our brand-new clinic in Brookfield. You all viewed that clinic. We're located on the second floor. You're greeted. You come up. You have an appointment, or you're a walk-in. Or it's an employee health-related issue. Maybe Kay's called over and you've hired 10 new teachers and they need pre-placements and drug screens. And so that team is used to working with whether it's a primary concern, an employee concern, or an occupational concern. So it could be a walk-in, they could have an appointment, or they could have scheduled online, or they could see the virtual provider. They have all those activities. So as they come in, it will say ProHealth Care. We'll know who they are. Obviously, we ask you your name and date of birth, and then we know who you are and where you're from. And our service is tailored to your needs and your wants. So you're special, but we utilize our system to know that you're special, because Epic will tell us you're special. You're from the school district. You have UHC insurance. The premium designation information will be there. So if you come and see Dr. Kalimas, our physician, for something and you need to be referred to someone else, he knows what he's to do, and he moves you on to the next level of care. What's unique about this is everything we put in Epic, whether it's a sore throat or it's a primary visit, if your PCP is anywhere in Epic, they will see that you had been seen. And I think that's of value because we're all part of one large family and team in healthcare.
One of the things, you talked about, there's not capital expenses for the school district, right? So one of the things that we're doing is we've made those investments of capital into these clinics that Vicki runs. And so the key is you don't go through those expenses. We're letting you kind of come on, on the variable cost piece of it. And that's where I think the major cost savings happens. When we make these upgrades to these clinics, school district employees get to utilize those same things. You don't have to make those same investments for yourself only. So I think that's one of the big advantages of doing this, is we're offering that up. We could do a clinic just for you folks, but then you got the capital, you got all these other kinds of things, you're kind of stuck with it. Where here we can flex up, flex down based on the numbers and the utilization that comes.
And we can build in our system a custom portfolio or program just for the school district. So Kay's needs and wants in the employee or OC health realm, we would be able to know that. We would also know what the agreement is between the school district and ProHealth Care and what services are offered. So we don't step outside of those. So we are able to utilize Epic, a very powerful system, not only for the documentation of the healthcare, but to manage the arrangement, if that makes sense. Okay. I'll continue on. Our commitment really with our employers is to, engage, make sure folks are healthy, safe, and productive. And some of the differentiators we wanted to point out today really is that Epic record. That's a one unified record that helps with duplication. It helps with communication. It's extremely powerful from a population health management perspective, as well as making sure that we can communicate with our patients. We're offering customized hours and location, a wide range of services as outlined in the RFI. But I wanted to point out we're healthcare consultants as well. We're just coming into the middle of our pandemic, right? We wish we were coming out of the pandemic, but I think we're in the middle of it. But items like the pandemic and COVID and other things that come up, being attached to a health system where we can partner and help you as we negotiate those types of activities. And our virtual options, as well as the ability to scale up or down. So if you choose 3 and you say, oh, we only need 2, that's okay. If you say, oh, we'll have 1, but we'll move to 4, that's okay too. So that ability to scale.
I would also say that as a part of our evaluation, ProHealth Care did a very exhaustive study of the current utilization of the clinic. And what we determined is 1 location at 40 hours a week may be a little light. A full 2, if we were to do, 80 hours a week, that's probably a little heavy. So somewhere they've created an opportunity for us to create flexibility there somewhere between. It's not all or nothing. Because again, their staffing model, where it might be different or more difficult under a different scenario to get a half-time or a 10-hour person or something like that. So that ability to flex is really, it really does ultimately affect our cost.
And once again, we're going to learn, right? So, I mean, if you just have your single out there, it's 45 hours a week, you're going to have dead times and you're going to have live times. And so, if we can adjust that, I think it's going to work out well. And by adding virtual, that's a big deal. So that's, teachers are at school, they can make a call, or they've got a child that's sick and a spouse is at home, and they can do that. There's just so many ways that we can utilize this staff in an effective way.
I think our next slide is on our ProHealth Solutions, and Pete, you're going to take this slide.
Yeah, so one of my roles is, these are called accountable care organizations. The federal government had set this up for Medicare, where they want the physicians and the health systems to work together to look at improving quality scores and lowering costs. And our organization is ProHealth Solutions. It's a joint venture between Waukesha, ProHealth Care, and also the independent physicians that are located here in Waukesha County. We've had a great experience with this. We've done a great job working with the payers to look at these kinds of things. When Vicki says that they meet every week, and United Healthcare, we work very closely with United Healthcare. She knows how many of your patients have not come in for colonoscopies, who has not come in for, their immunizations, who has not come in for all these kinds of things. And that texting information that we have now, we're starting to utilize that to try to pull them in and get them engaged to come on in. Because that's how the insurance companies want to work with us. They want us to get rid of, they're called gaps. They want us to close these gaps because, once again, you close the gaps early. It costs you a few dollars early, but it can cost you a lot of dollars if these things aren't addressed appropriately. We also have risk scores on all the patients. That's the other thing that works out really well. So she knows who are the people that have rising risk and who are the people that are in a tough spot, and how do we keep them engaged and informed in the process. That's what our ACO does. We have a dedicated group of people that they think about this stuff all the time. And like I said, they work very closely with all the payers. So once again, we've done a lot with United Healthcare. Our ACO has not only a relationship from the Medicare side, we also have a commercial relationship now, and that's where I think that experience really pays off. We all have the data. They have their data. We have our data. We merge the data to make sure we fully understand where that patient is. And then they set up strategies on how we're going to attack that. So a lot of times whether it's to our clinic that we're talking about here or their primary care physician, they get notes saying, you got to get Joe in to do this. And then the call center calls Joe. Joe will come in and get his work done. It's really driving that. This is so much different now than when I first got here 6-7 years ago. She's done a lot of it.
We also wanted to touch on promotions. So as we go down this journey and hopefully we're chosen, how do we make that transition and that plan? And I think it's really key. We will be using our ProHealth marketing department and dedicating resources to that. A number of tactics that we thought about included like web contact, a personalized newsletter, emails, texting, posters or flyers, the old, If people can congregate in the cafeteria someday, we might, including postcards and letters. It's really critical that we have a good transition from one to the other, as well as ongoing messaging. So I'm not going to read the next two slides, but you can kind of get an understanding about what we would promote, the scope of services, the locations, the hours, the services available, and then we would want folks to have a monthly newsletter that we would tailor to the clinic and to your constituency, and our marketing department has committed that to us if we're successful with this agreement. Questions and discussion?
So as you know, and I think is outlined here, we have two distinct approaches to this thing. And I'll let you decide in the end. I mean, we'll probably make a recommendation next month, but we say clinic now, but the version of ProHealth Clinic is multiple sites, heavy into virtual, so it's not that brick and mortar thing that we all grew up with. So a lot of differences. One thing, I'll point out just a few things that I thought led me to thinking we need to bring this forward is the scaling up and down, the technology, the access to information, I guess would be the three things that I'd like you to walk out of here thinking about as we head into our meeting cycle in December.
If I could just add one thing, Darren, as well, and you may be wondering, well, what are we giving up for $400,000 or $500,000 a year? I mean, that's right. And so, again, the goals of the RFI were to say, we made a good decision to provide employees access to quality health care 7 or 8 years ago. At that point in time, the form and fashion that was delivered in the marketplace was a single employer clinic that we thought was centrally located that could be accessed by most employees. You fast forward to now and you hear and see about technology improvements, electronic medical records, multi-location access, scale up, scale down. I would say the one distinctive or one contrast would be today, a lot of services are performed by a MD. Under this scenario, we could say MDs only, but the vast majority of the services would likely be provided by a PA or an NP, which most of us get on the front end of our personal care anyways, or sometimes all often. Aside from that distinctive, all the things that we've talked about around access, technology, are present, and the cheese has just sort of moved in the last 6 to 8 years. And so we would say, as sitting on your side of the fence going through this RFI, that if your objectives are to improve access and leverage the technology and reduce cost, this is a great option for you to consider. If you're satisfied with the model that you have today, that's a good option, will continue to be a good option, but it doesn't address the objectives of the RFI. Does that make sense?
I really strongly believe that our population has driven us in this direction, because our utilization at the clinic continues to decline, regardless of all the marketing and whatever else we're doing. They're very late, to the party in respect to bringing us technologies and reporting and all sorts of things. And our population says we're not going anymore there. We're going to ProHealth Care. They've chosen to do that on their own, regardless of what we have in our plan or any of those types of things. So that's, our population wants this to happen.
Wait.
My question has to do with the annual biometric screening. How does that fit into the mix of this in terms of like kind of a wellness check per se of the staff members that we're accustomed to?
Yep,
Yeah.
I can speak to that. We can mirror that and beyond. We have been in that book of business for 30 plus years. Health risk appraisals are near and dear to my heart. I couldn't sell them 30 years ago. Now people really love them. That questionnaire, that biometric assessment, that coaching, getting you on the right path, making sure your PCP sees that in your EPIC record, so it's not over here somewhere and they want to repeat your lipid profile because you said it was elevated in your book or in your communication with your provider that did that. That was a major coup for us. Pete helped me do that 6 years ago to put all of our HRA information in Epic. And we started with our own employees. Like I said, we test a lot of this stuff out with our employees, our 4,800 employees and their spouses and dependents to make sure things work effectively. And so when you have your screening with ProHealth Care at 7 in the morning, by noon you have your results, and guess what? Your PCP might be calling you or emailing you to say, we need to talk. And that is real anecdotal information that has happened in our screenings.
She's not kidding. 7 o'clock, it's in there by noon, and that's a crazy thing. And today, I still remember I used to work at Assurant for a long time, and we do these HRAs. I get the sheet of paper, I'd slide it in my desk drawer, and it'd stay there for a year. And all those tests, the things that I had done, all my results, wasn't tracked year after year. Once again, this feeds Epic, and so when people look at it, they can look exactly where any of their labs are year over year, and they can really get a feel, how are they progressing as an individual.
I'm glad you brought it up because that's where this conversation with ProHealth actually started. It was around the HRA and biometric screenings. And they said, well, what are you doing with the results right now? And we said, well, the employees get the results. What do you mean, what are you doing? Well, we've got a system, we put that all in their medical records so that the PCP now have access to it. So when we talk about really trying to not only enhance the customer experience, but improve healthcare, the notion that someone's, got borderline, maybe pre-diabetic or high blood pressure or something like that, and it goes off in a silo and it doesn't go to the primary care physician that's treating. It might go to the person at the clinic, but if your employee doesn't go to the clinic, it's siloed over here and their physician doesn't know about it. Now it gets automatically linked in, the physician knows about it, and they can make the call proactively to get that employee the help they need. So that's exactly where this conversation started, probably about 2 years ago.
Joe?
Thank you, Dan. I really now I'm really understanding how we're able to get the savings and to increase the savings. I really enjoyed the presentation. It's really smart on how you make all of your resources essentially available. You're spreading the cost over a larger populace too than what our clinic serves right now, which is the city, county, and school district employees. So our populace is smaller and is dedicated to us right now. But by having this go to all the clinics that you're running right now, or at least 3 to start with, I'm understanding how you can be efficient with those resources and how you can pass on those efficiencies to us in dollar savings, while actually still improving the services. It seemed too good to be true when we first started to do this, but I truly do appreciate how you went and explained this to us in detail. I do have a question though. Do you have any other school districts or private organizations that we have public agreements with at this time, or will we be the first one that will be being a model for this?
No, you're not the first one. Our first activity in this was over 20 years ago. And we did exactly what you're trying to do now with them. We had 1 site, then 2 sites, then an entire network. And then as we move forward with other groups, we do individual things like they just want the HRA, or they just want the flu shot, or they just want OC Health, or they just want employee health. And that's the flexibility. You don't have to have every single service. You can flex in and out. And like I said, Epic and our portals are able to streamline and be able to know what your portfolio and you have chosen, so that when you come in and see one of our providers, they know when you say your Waukesha School District, they know exactly what services we would be providing you. So we've done that for many, many, many years. So we do have some track record, and you won't be the first. However, I would like to say that as we move forward, we want to be very innovative with you. And virtual is a new ad. That's been only a year. So that is just on the beginning of our cusp of working with you, whether that's a virtual urgent care or virtual primary care. So we're just a year into that. But I would like to get deep into the data and analytics around your population and continue to improve the quality, the patient experience, and reduction in cost of care over time. That's what I'd like to continue to offer.
Joe, we have a military boarding school just down the road. I don't want to say the name. We've got other schools where we have lifestyle nurses that are on site.
Yep.
We do it with a number of employers. So this is feeding right at us. Using these clinics to have the people come in, this is a little different, newer model. We've done it with some larger employers. But it's how we do business. I mean, and that's why we said it's important to let the claims flow through United, like we said, and then we'll reconcile and we'll do all those kinds of things. So it just will be a seamless, it fits right into how we deliver care today, and that's why I think it will work very efficiently, very effectively. And you're absolutely right. We've built the infrastructure. We're not charging you for $1. We're using the variable cost model to bring more people in through the system. So you hit it right on the head.
So, if we were to move forward with this and form a partnership, what kind of time would you expect out with our administrators? What's our commitment to you in terms of, we run a pretty lean business like this.
Yep.
But, you know, there's probably going to be some commitment that we have to make to you guys. Can you give us a sense of what that is?
Darren and Kay said they wanted to do more with the clinic. No, I'm kidding, obviously. So one of the things that we built into that quote up there is we have people that are dedicated from an administrative standpoint. You folks have other stuff to do, and they should be doing those jobs. You're hiring us to take this off your back, and that's really what we're going to do. So when you saw those costs up there, we had really, I think, 2 different people, at least one, that they're going to be thinking about this all the time, and that's what their role is. So we fully, if your work goes up, then we're wrong. That's not our goal. We want to solve. And one of the things about having Vicki here, she solves problems. She takes pressure off of people, and so they can actually do the other parts of their job that are going to provide, value to the school district.
By contrast to that, Kay, what is your involvement now with the clinic?
My involvement is way more than it should be right now, because there's staff turnover all the time. Just to give you kind of a ridiculous sort of thing, last week's meeting was, we want to post a sign for our sick patients so they only go through a certain door. And what size should the sign be? Should it be laminated? That's the kind of stuff I have to spend my time on every single week with them. So I would be happy to get out from underneath that, especially now with everything that's going on with COVID.
Vicki's team has low turnover. And I truly mean, the time we have turnovers, a lot of these people are 20, 30-year vets that are retiring. I'm not going to say we're never going to have turnover, but, we just got selected by Forbes as a top employer in the state of Wisconsin. So that tells you something. And people want to work here. We have a great place. We have great longevity. We have long-time employees. And that's what we want to get to. We look at the boarding school down the road. Those folks have been there for a very long period of time. They build relationships. They do this. It's not a stepping stone. This is where people want to go to work. They want to live and work in this community because it's such a great place. That's the environment that she's built for her staff.
Joe?
Jeff, this is probably more for Jeff. What type of timeline are we looking, or duration for a contract that we're looking at? 1 year, 2 years, 5 years? What do you have in mind here? And then, not to preclude the ProHealth people from answering that, but I would like Jeff's opinion on that also.
Today, I think you have had historically a 3-year agreement with HealthStat, right? Which maybe added maybe there was 2 3-year and then a 1 or a 2-year.
I think wasn't there initially a 5-year?
There was initially a 5.
Then we went down to 2.
And then maybe 1 more or something. I'm not sure. But I think that in order to give this a reasonable shot, you want to be in it for a couple years. I would just say that out of the gates. I would also say that the ability to flex at a 6-month interval, I would say, we'd probably want to give it our all and do something well for 6 or 9 months, maybe in the first year. But then after that, be able to flex every 4 to 6 months. We don't want to do this on a monthly basis, increase, change hours, all the rest of it. We want consistency. But I would say, Joe, if we were to start with a 2-year, which I'm assuming would be amendable to you guys, and then be able to have some language that says at every 6-month interval, we'll have a conversation about staffing, our utilization, how we can improve it, or how we need to move it up or move it down. That builds in a lot of flexibility for the district. And, I would like to think that this would be a model that, since it is flexible, even if it was a 2-year arrangement initially, would continue to grow and extend itself because of the flexibility inherently that's built in.
The other thing that I would add is, today you're doing a calendar year. You may want to consider doing it the school year. Is that how your benefits roll?
Yeah.
So you got new teachers coming on, you're splitting different things. We could do a stub year and then make it roll. I mean, we don't do a lot of long-term contracts. We don't have to. We think we service the people. I think it keeps everybody fresh and engaged, and we have no problem with that.
Joe,
If we were building a clinic, that'd be one thing, but we're not. We've got the infrastructure built. We're looking to put you folks on that infrastructure, the rails that have already been built.
Does that help, Joe?
Yeah, that does. I like the flexibility in the contract side of things also. I like the stuff year that you suggested potentially, and 2 years I think is good. And if you want to be shorter and you're comfortable with shortness, the proof is in the pudding. I like that. Thank you.
Just so everyone knows, we asked ProHealth just to send us a contract to even see, this isn't a contract you deal with very often, so we are already kind of reviewing an initial, a template, I guess, contract to get up to speed on questions we should ask or discussions maybe we need to have. But from the draft I saw, I always jump to what's the termination? How do we get out? It's easy to get in, and how do you get out? And those terms were very friendly to both parties, I think. So.
And once again, we're part of the community. If it doesn't work for you guys, it doesn't work for us. And we're here to help you, to try to save money and so you have more costs to take care of kids. Imagine that, right? So that's just not in our DNA. But, I think we'll service you folks to death, and then you'll want to keep it going.
One other thought I forgot to mention, as you were talking about, and Jeff was talking about rolling out, and us, maybe for the first 9 to 12 months, just kind of finding out where we are in terms of services. My gut, I'm hoping this is true, and I'll look for nods. If we're saving $500,000, that learning curve could be funded in savings and not costs. So if we're going to save $500,000, and let's say $200,000 of that goes out to maybe services we end up not utilizing, house money, essentially. So it'll make us, I think, a little bolder, and the sooner we can, if we go down this path, the sooner we can start saving those dollars. It'll help protect our primary health plan rather than health plan changes coming to you, was it every February or so? So that's the ideal scenario if we go down this path.
Darren, the other thing I would add, it's not just the administrative costs we're talking about. It's that ability for our clinics that we're talking about here, that they're referring to premium designated providers, and that's what Jeff had talked about before. The more people that go to those providers, first of all, they're going to get a better deal because they have a higher benefit level, but over time it should lower your costs and improve your quality. And so that's the thing we can make at those clinics. They're going to make those referrals over. So it's a combination of savings.
Ready? Any other questions? Sherry? Sure, you're more than welcome to share it.
Matter of fact, I have to pay the $5 right now.
8 years ago, I was diagnosed with cancer. I lived out near Madison. I had a very aggressive rare form of cancer. So there was not one specialist for what I needed out there, and it was a competitive insurance company, and they actually sent me to ProHealth in Oconomowoc, so I had to drive to Oconomowoc to get my treatment. Incredible. I mean, I was with them like 11 months, and it was incredible experience. And I had a 55% chance of being alive at 5 years, and here it is 8 years, and I'm still kicking. So I want to thank ProHealth. I think it is by far the best, and I know that's not from a clinic perspective, but from a company perspective, it was an amazing experience, the whole thing, so.
There are a lot of good stories about ProHealth Care, because staff members share them with me all the time. And they do love the technology, and trust me, I'm a MyChart user. I love all the reminders and the text messages and the things that I need to take care of as an individual as well. But yeah, I get a lot of really, really good feedback, which is why they keep migrating there. And our staff talk to each other. When you have a bad experience, everybody knows about it. When you have a positive experience, everybody knows about it. So yeah, it's been great. It's been good. And it's been great from my perspective, because the less trouble I have to deal with in managing this plan, the better off I am right now.
You don't want to take away from COVID, right?
That has been a challenge, I will say that.
Yeah.
but,
Well, and interestingly enough, the vast majority of the COVID test results are coming to me via MyChart. So they're using it out there.
That's all we have, and we can answer, this is a big topic, and it can get very complex. We don't want to minimize it, so answer any more questions you have tonight. I'm planning on bringing it back next month. I don't know if ProHealth will be here unless you request them. But then a decision, again, we're not contractually obligated to make a decision in December. I just think it's more of a courtesy. But if you think of things again, because this isn't as simple as a bus contract or something. Healthcare is a lot more difficult. Let me know, or let Patrick know, and we can make sure we have answers for the next meeting.
I have just a couple things just in closing, if that's okay. I mean, we really do appreciate you folks taking the time. These are unique decisions. When you did the first one, that was a pretty big deal in the community. It has changed. I'm sure they're going to look at different ways to try to provide some care. I just think we outflank people. The technology investments that we've made, the Epic, MyChart, if you can't duplicate that. Either you pay the extra money and you have access to that, or you don't. The technology, I know we talked about texting, but one we didn't talk about was online scheduling. People can actually go in and schedule their appointment online. What a savings that. You don't have to get into a phone queue to do those kinds of things. Those virtual visits are huge. You have great substitute teachers, but they're not the same as the actual teacher, right? And so if we can figure out ways to take care of their families and them a lot more efficiently, where they're not out of the classroom and doing kinds of things, that should be another savings, not only from a cost standpoint, but really from, delivering education. As we all know, the last year has been hard. We've got to get these kids caught up, and they've got to keep on track with the academics, or that generation's gonna fall back a little bit. We work very effectively with UHC. She knows exactly who has or has not come in for the right things. And when you've got people that can push it because they have access to that data, that's where you really begin to make a difference in the lives of your employees. And let's face it, it's not just your employees, it's their spouse, and it's their kids, and it's everybody else. So if we've got that data to go and do those kinds of things, you're just going to have a better outcome. You're going to have a happier workforce, and they'll be more effective and hopefully healthier. And once again, just doing the HRAs, getting that information in the system, building a record, building a history, it's just going to be a better outcome for them long term. So, we're part of this community. Our employees, pay taxes to make sure that we have a great education system here in the area. And if we can save you a few dollars on the front administrative costs, and hopefully save you a lot more on the medical expenses by using the premium designation, I think we should be in a really, really good spot. And we're really excited about this opportunity. You're not going to be the first school district that's going to see this. others that we're beginning to talk to, they really like this format. And it is much different. Walk-in, schedule appointment, or virtual. That's a different play than what they've seen in the past. And appreciate all your time. And Vicki, she's the star of the show. I tell her that all the time. She is so dedicated to doing these on-site employer arrangements. She's got 5 other jobs to do too. But she will take the administrative burden off of you folks. And, I think we do a nice job for the community. Thank you for your story. I was in the insurance side for many years, so I went to Dean in Madison. But living and working in the same community is new to me, 6-7 years ago. But that's such a blast to see how many of my friends have those kinds of experiences. Not everything goes right, trust me, I get that. But boy, there's sure a whole lot of great stories that come our way, and we want to take care of this community. Focus in on this community, so appreciate your time. And if you need us to come back next month, more than happy to do that. I love wearing these masks for a prolonged period of time. It's really
We try to set a record every night.
Yeah.
All right, well,
Thank you.
Thanks, Kay. Thanks, Jeff.
Cool. Yeah.
Big deal, which I know everybody knows, but is there a way to get the participants, our employees who are going to be doing this, to have kind of a bounce stuff off them, get some sort of little ad hoc committee, or I don't know how you would do that, because
Could do a
it's
survey.
their kids they're going to be sending, their spouses. Yeah,
They're effective.
something, yeah, okay.
I think Kay's a great measure because she's interacting with
Yep.
staff and usually not on the great side. If everything's going smoothly, they don't call
Right.
Kay, right? I mean, it's the, so I think Kay's a good measure. I do think a survey, my only concern of trying to do a survey is complexity of, we haven't spent a lot of time, and I'm sure we. And I was trying to I think it's harder because they're dispersed, every school. I'm trying to get some feedback because the clinic gets high reviews.
Oh.
We've all seen them. From a fiscal standpoint, it's more, not enough people go there to make, in my mind, struggle to overcome the fixed cost portion. But I think we can get some feedback.
So I guess where are those people going?
Yeah, it certainly seems antiquated, inefficient, everything you guys all said, but it's a big deal. I mean, the most famous line in politics in the last 10 years was, "You want to keep your doctor, you get to keep your doctor." So it didn't work,
Well, the health clinic was a reaction to that.
Yeah,
It was a reaction to Obamacare.
it was,
To
okay.
keep the health
Okay.
insurance under, so we didn't pay Cadillac tax on what we were providing our
Okay, all right.
employees. So that's, not a lot has changed on Obamacare since
Okay.
its inception. So that is also something that's changed in that whole formula of why we went with the clinic, this clinic.
All right.
But the comforting thing,
Right.
people have voted with
Yeah.
their feet. So, in terms of structure and how you roll it out, I think that's
Well, I think that ProHealth Care does a good job in generating that business. They just bought my doctor's office, who was not with ProHealth Care. So now I'm with ProHealth Care. So I'm part of that 67%. I was just there today. So they do a good job generating it. Diane?
I think it's a great plan, and my concern with surveying the staff is like that they'd want to start like our stub year, like immediately in January, rather than this being a year out. You know, I think we have to look at the fact that they are making their decisions by the health choices that they're making. You know, and our declining number of people who use the clinic. You know, I think that those have spoken volumes. you know, and the satisfaction with ProHealth Care is coming back every time they walk out of a service providing
Right.
situation. And the fact that they're at, you know, the alternative, we know through the survey kinds of results that they're building into their, you know, automatic system. You know, so I think you have to be careful how you present it to the staff, because I think there'd be a lot of people wanting to do it sooner rather than later.
Yeah, and keep in mind,
For another year.
for another year, so we don't want everyone to.
Yeah.
Yeah, right.
Yep.
And that's why we haven't.
Yeah.
Fine line.
Alrighty. Any further discussion? Alrighty. Moving on to the 2021-2022 Budget Development Calendar and Budget Assumptions.
Just a couple of quick things. Attached is the 21-22 budget calendar, just so this is what guides us through the process. And it doesn't change a whole lot. We start in November with this discussion right now, and then by state law in October, we certify a final levy and budget. So we're trying to get a jump on the actual more nuts and bolts part of the budget development, because with COVID in place, entering a new biennial budget next fiscal year, trying to figure out what are our assumptions going to be. So I jotted down to some very rough ideas to start with. As I mentioned last month, we looked at enrollment data, both resident enrollment and open enrollment in and out. Right now, if I was asked, I would say our resident enrollment's artificially low. I think a lot of 4K kids didn't come. I think, summer school didn't run like it used to, so we lost some numbers there. I think a lot of people migrated to open enrollment because of eAchieve from other districts. So I think open enrollment's probably overstated and resident enrollment. So Sherry and I have to come up with some guesstimate of where we think. And through that all, our budget, or our enrollment projections show that we're going to have a continuing declining resident enrollment. So we have to factor in all those things to come up with those numbers to start building something around. So I won't walk you through all these. You can read them at your leisure. Some of them are not very different, but I just wanted you to know that we are getting underway, and we will be presenting a budget forecast in January like we do every year. And we'll, again, follow this calendar roughly. The big date cost-wise is May 1st, because that's when the teacher contracts go out. You're locking yourself into a significant part of our budget there, so we have a lot of work to do between now and April.
Okay, any questions on that? All righty, moving on to the demolition of the vacant house at 339 Arlington.
This is just truly something to think about topic,
Okay.
nothing that's being pressed by any timeline or anything. But the property that we own across from Les Paul Middle School on Arlington, the primary residence, which I think was a small apartment building's the right thing, but a multi upper-lower kind of arrangement, that residence had burnt down, and we bought that land with only I guess what I would call an in-law suite, a very small building. There's pictures on the back. It's not in great shape. Do we want to maintain that building? Again, I don't need an answer tonight, but I thought I'd bring it forward just to have us start thinking about it, and whether that decision's made next month or a year and a month from now. I'm fine with either of those, but.
I guess we should get some bids.
Yeah, and we're
you
in the
do?
process of getting those.
Okay.
I think Tim already has one already, but
Okay.
I didn't have three.
Sure.
I just wanted to see if there was any general interest, and if there is, we can pursue it.
Ms. Reincheck.
I thought we talked, thank you. I thought we talked about having the fire department practice on it.
Oh, yeah, I guess I don't care how the mode of that happened, it's just, do we want to bring down the building, whether the fire department, if they can get something out of it, I'm more than happy to work with the fire department to make that.
I think if I was the neighbor, I would want it down. I I was a business owner around there, I'd want it down. I don't think it looks very nice for anybody. Not for our city or the immediate surrounding places, so.
I'd be concerned about squatters.
Attractive nuisance.
Yep.
What about liability too, or liability? I think there's exposure if it's there, but our insurance rates go down if we get rid of it or destroy it? Is it just too small?
It'll go down, but with all the
appreciate it.
properties, we own, we own 0.3 million square feet of facilities. This,
Yeah, 400 square feet, it's not going to make a, okay.
it's unique in the sense, like you were saying, in terms of squatters and
Yeah, well, that's the
the
problem.
impact on the surrounding properties. I think it's different in that way, but financially, I don't think it's a big play.
Wait. Yeah. Yep, and then Joe, yep.
My question would be, could we, if the building is down, could we convert it into some green space that the kids across the street could get out and use? You know, because it's so close. And you know, and right now with all the construction stuff, a lot of their space is very much limited. But just to have it be a space to go and sit and be able to do an outdoor activity. And once this is gone, right now, there's no way we could even consider having them to go over there, but that it could just be, you know, potentially a green space. Right, right. But yeah, if we could get it to the point
Yeah,
that
I
it could be a
think that we
green
would
space,
dig it down and plant grass on it, is what we would do. That's
it'd be
usually what you do.
a lot more positive and practical
Yeah.
than the way it looks right now.
It is the complete opposite of what we intended. However, I don't think the plan commission is going to go with our intentions, is the problem.
If not a green
It's
space, it would be
just, it's,
paved.
you know, it's just an opinion. But I don't think we're gonna get much traction, from the city on turning just that parcel into a parking lot. I think it's gonna have to be a little bit bigger. Yep. Joe?
How does this work? What happens when it's burned down? Do we then have to clean it up? Do they clean it up? You know, those kinds of questions.
Okay.
Diane?
Another aspect, another possibility might be WCTC and their fire service program as part of their training. You know, as another option. You know, and
Yeah.
I'm always all about
Right.
trying to find places for kids to
Right.
get experiences and what they want to try to learn
And
how to
maybe
do.
those two entities work together on those
Yeah,
Yeah.
events. I'm sure the fire department would have to be there for that in some
I
capacity.
think, yeah, I think they have to be on site.
And this might not come back next month, but it might work its way back up of the
Right.
pile, and we can.
I think it's a good idea.
Alrighty, moving on. The monthly budget report.
Hey, from a revenue perspective, for the local sources, going into the final budget, I had made quite a few adjustments in the local sources. Some of the bigger ones were admissions, brought that down from about 110,000 to 8,000 because we're not charging admission currently. Right now, any events that are there, they're only allowed to have 2 people come, and to pay workers to come manage that is just not worth it. So everyone that's going is being allowed in. Talked to some of the athletic people, and they felt that maybe spring soccer or something like that, but they doubted that there was going to be anything this year that they would be able to lift that 2-person ban on. So we dropped that quite a bit. Interest, most depressing part of all, we dropped that down to $100,000 for the year, because going into the first 4 months of the year, we're only at $19,000 in interest compared to last year. We were at $255,000 this time. So that was another area that I brought it down. You know, hopefully things will stabilize and get a little better, but we don't want to count on that. And then the student fee budgets were brought down, and they're pretty in line right now with the percentage of collection where we expect them to be with the lower budget. State sources, the only thing we received was Robotics League grant payment. That's a payment off of their expenses from the prior year. Other sources were just minor things. damage reimbursement, contract liquidation, those type of things. Other than that, there weren't any other sources that we received, and given it being a crazy year, I'm comfortable with where we're at with what we've collected so far, and I'm comfortable that our budget is in line with what we expect to have. From an expense perspective, salaries, it looks low in a percentage perspective, but we have to keep in mind that we haven't put in any adjustments for this year. So there'll be the addition of the adjustment, and then any retro that goes along with that will cause that percentage to increase. So it's, again, in line with where we expect it to be. Purchase services, mainly utilities and tuition, which is normal for this time of the year.
Mrs. Boyd.
Before you turn the page.
Yes.
When it comes to salaries and benefits, is there a good chance that we'll be able to take care of the back pay before the end of this year?
Well, it's a lot of work. I know that that's the goal, to try to have it done, but
We're hoping to have it done for the group that we've settled with. COVID's added, I mean, couldn't have imagined the work that trickles through. People going in and out on leave, and they're going from virtual quarantine, and they're doing this, and it's added, I would say, at least 2 days to each payroll cycle.
crazy.
We'll be talking at HR, we'll be bringing forth salary recommendations for all the non-teaching groups. Some ideas we have that might lighten the workload a little bit and still achieve.
I don't know if this will be the case, but in the past, whenever we've had that type of situation, it isn't that they get one check suddenly with all the retro on it. They calculate out the rest of the contract and divide it up by the remaining pay periods for that year. So it gradually catches up by the end of the year. It's not just a big, but I don't know if that's what we're still looking at this year or not. I'm pretty sure it is, but a little easier to do it that way, especially from a taxing perspective. It doesn't really mess with people's taxes getting a big lump sum. Other questions on that page? Otherwise, I'll flip the page. Overall, there really isn't anything remarkable. The same things are typical for this time of year, technology expenditures. Our supplies continue to be one of our bigger areas, and a lot of that is the PPEs and the cleaning, and as we talked at the last board meeting about potential budget amendments, that would be one area that I would, expect if we're going to see it, it's going to fall under there because of, and we're pursuing every opportunity for getting money back, be it FEMA, using our ESSER funds. We tried to piggyback off of the municipalities' road to recovery grants, but they weren't in a share mode, so that fell through. Under insurance, the unemployment payments have really dwindled, so everybody's back working now, and there's just some straggler things coming in for people that they had something that was keeping their file open, and now they're coming in, but it was down to about $20,000. The good news is we will be getting majority of what we spent back. 50% of that comes from the federal government under the CARES Act, and the other 50% comes from the state of Wisconsin. I believe it was Act 186. I should have made myself a note, but I'm pretty sure that's what it was. The problem is nobody knows when this is going to happen. It could come next fiscal year, it could come this year, so we haven't budgeted for that money to be returned because we don't know. Nobody can tell us when that'll happen. It's a massive undertaking to do that. So, but it is good that eventually we'll get that back. Other than that, our overall spending came in at 11.48% of our approved budget, and at this time last year, we're at 12.22, so pretty much in line with our percentage of expenditures. Fund 27, we didn't get any special education revenue in October, but we never do. It usually starts around November with our first categorical aid payment, and then the grants start coming in after that. Purchase services, mainly tuition payments to private schools and student transportation to our bus companies. Their supplies were the only non-capital objects, and there were no capital objects, no insurance. So overall, it's where we are normally at this time of year. Fund 43, our interest, it's low, but the good news is we invested a lot of the money when it first came in. And so we're locked into CDs that are maturing as we go along here. And so we'll be seeing a higher amount of interest in Fund 43 than we will in the other funds, just because we have CDs locked in. And then it's just the expenditures continue to be our construction, those type of things. Any questions on the budget before I go on to the tax pages?
Oh, Joe.
Thank you. Two of them, Sherry. Under Fund 10 for our insurance and adjustments, you mentioned that unemployment payments will be split between the federal and state government. What is that total dollar amount?
Oh, I should have written that down. Because it's crosses 2 fiscal years, it was over 750,000. I think it was just under $800,000 that we could attribute to COVID. Because you're only going to get reimbursed for unemployment that is attributed to COVID. We had a few people out, but that would have been about $2,000 for the year. So it'll be close to $800,000 that we would be getting back.
That's good news. We'll see when we get it though.
Yeah.
You said we're not sure when, but that is good news. And I have a second question under Fund 27. You mentioned that we still have some unfilled aid positions, and I know that's been kind of an ongoing case this year. Do you know how many are still unfilled at this time?
I don't. I have that question into HR, but they're still working through how many positions they need. They have pretty much a perpetual listing out there to get aides because it's a difficult job, and they're doing some things to try to improve recruitment, like aides. There's a fingerprinting process, and normally aides have to pay for that. Now we're picking up paying that fee to try to encourage people to come without having to add that personal expense in there. So I know they're doing everything they can to try to get those positions filled.
Last time I talked to Marge, we had made progress. The original number was like 28 is the number I have in my head. And we were down in the upper teens, and that was a couple weeks ago. We just continue to have people leave too. So it's not a matter of just circular flow, but we have made progress. And that, like Sherry said, that perpetual posting is out there. But we can get a firm number of that.
Double check on that. Welcome. Okay, then the next page is our tax collection, what's actually page 18, our tax collection update. This just shows how the tax levy was broken out across the municipalities. The levy report was filed with DPI. All the municipalities have gotten their certification forms. So Diane graciously came in last week and signed with Sue notarizing, and they all went out certified mail, and I have all the responses back, so we know they've all been received. This won't have any further updates till January when we start getting our first tax payments, so I'll leave it off to save paper in the next couple months, but I'll bring it back in January when we have some change to it. Any questions on the levy page? Okay, then the next two pages are just our self-funded insurance. Our claims experience still continues to be, I don't even want to say this out loud ever, but good. And we're still sitting with a very hefty amount of money that is available for claims. So I know at some point the floodgates will open, but they have not opened yet. Dental is people are obviously starting to go back to the dentist because that we're eating into our balance. And it's still, though, at a really good position. There's nothing to be worried about. We expected this to happen, and we had a higher balance going into it. So that's my update, unless there's questions.
Questions? Joe?
Because of COVID,
I don't have any official sense, but I know I have two friends that are getting knee replacements in the next couple of weeks, or an aunt and a friend were originally scheduled when COVID hit. So it's taken this long for them to be able to go back in and do it. But I don't know, I'm sure there's many people that still aren't comfortable being in a hospital setting, but I don't,
Yeah, we can
Darren, do you have any official type?
We can get you an answer on that, Joe. I know they're doing more, but they're not back to full strength, I can tell you that.
I think the dentists seem to be more open to full everything now from my experience, and what I've seen, but medical, I think people are still a little more nervous.
Yeah, there was just a story that the hospitals were going to limit those procedures shortly.
I think they still are, I just don't know what. Before, who would have thought a pandemic would lower our health insurance costs? Right.
It is. All righty, moving on to the food service request for proposal timeline.
Okay, so I brought this up last month as a potential topic, but just to recap, every 5 years, we have to go to bid for our food service contract. It's a USDA requirement, and they are not giving us a break because of COVID. So we are in the process of creating a food service RFP. Now, DPI has a very strict format that we're required to use, so we're just data gathering, but generally you report on your prior year's experience, but COVID's really changed that considerably. So we're working out what are we going to do, 18, 19, or figure a daily average prior to when COVID hit, because Aramark was seeing a lot of increase in participation last year before COVID hit. So we're working through that. The main reason I'm bringing it to this committee is because we'd like people to help evaluate the RFPs when they come in. So there's a timeline on the back that you can look at. Now, the timeline hasn't been officially approved by DPI, but it follows all the DPI standards. So our base thing is that we'll be sending the RFP to DPI for review on December 11th. And then there's all sorts of different checkpoints along the way that we have to follow. But basically, the evaluation period will be, we're accepting the sealed proposals on March 12th, and then our goal would be to have them evaluated in the next 2 to 2.5 weeks and be able to bring it back to I'm assuming it comes to this committee first, so FNF in April. And, you know, I think the last one came back in May, but the fact of the matter is, with things as crazy as they are, and if we have to have someone if we change and someone has to be ready to roll on July 1st, we really want to make sure we're giving enough notice there. It's going to be different, though, because they're supposed to be able to come in and tour our buildings, and I'm going to see with DPI if there's some way we can do this virtually and talk to Steve about, you know, can we go through with cameras and have some kind of a big Zoom, because not real comfortable with having people just coming into our cafeterias while everything's in the full swing and everybody's there eating, because that's when they want to see them, is while it's going on to look at the volume and see how it's being handled. So they're not going to get a true picture of what our food service normally looks like anyways. So we're just working through all of those type of issues now. And in the past, they've come to bring food in because they want everybody to taste their food. Well, I don't know about anyone else, but not real comfortable having people bring food in.
Normally, we also go and have site visits.
Yes, we go to other schools that
Well,
use them.
an option, so. Luckily, DPI's there to walk us through every single step of this process.
Absolutely.
Streamline it.
They are really helpful with this, so.
I think they should just tell us. But
So, I mean, I will say Aramark has been absolutely wonderful and responsive during this whole thing, and they have risen to the occasion, in my opinion, on how they have continued to feed our students and our community during this time.
Yep, for sure. Corey?
I'm sorry. I went through North High School last week, and I noticed, and one of the administrators said, look, Aramark's, I think, typically has 2 people at that station, and it was shut down, so the lines are long. They weren't able to staff it. I don't know, I mean, this is off topic, but I don't know who that's something I would.
Follow up with Stephanie.
I can follow up with Stephanie. I know that just like we're experiencing waves of COVID with employees, they have the same thing, and they're pulling people, they're being really proactive in pulling people just to be safe before anything hits. They have their protocol, and they've talked to our HR department, our team, to make sure that their protocol aligns with our protocol. So there have been times when, but they're trying really hard to fill in wherever they can, so I had not
Also-
heard that. I'll follow up with,
Because the
Also lost the
consequences,
luxury of, like in a school, there's so many kids and you need so many lunches and I'm not sure with this community approach, kind of hard for us to estimate, and sometimes with North rolling out kids and quarantining, and I'm not saying it's just that, but the target's gotten harder to hit as well, so.
okay. It just, yeah, there's a
But it's good to know,
solution.
if anyone has those issues with food service,
let me
Sherry's the
know, I'll
person to
follow up.
contact.
So this was last week? Okay. I'll follow up with Stephanie on that.
Diane, yeah, that's all.
Do you think DPI would give a waiver, till things are normal, to go through the process that would normally be expected?
I think DPI would, but it's not in their court, it's USDA guidelines.
USDA.
And
Well,
the
you think USDA would, it's still a federal concern.
USDA gave the 1920 people a pass for 1 year. So I think the concern is that you've already got a whole group of people from last year that are now coming on to this year, in addition to those of us that were in the 5-year cycle this year. And I think if you take this year and move it out, then next year you have 3 years' worth of people all, and that's a big stress on DPI to try to review and approve all the RFPs, because they do have to be approved before we can send them out. And it also puts a lot of stress on the food service companies to respond to all these RFPs, but that's the least of our worries. That's their problem, not ours. But I think the big concern is that to try to manage that many people going to RFP at once could be a little difficult from a DPI perspective. But we've been waiting. We've held off. Normally, we would have started this process a little sooner, but we've been holding off, hoping USDA would come through, but they don't seem to be budging on this one. So.
Joe?
DPI
That, I'll double check on it, but I'm 99% sure that that's part of the RFP. Is what it is it's the initial contract is actually a 1-year contract with the ability to extend for 4 years. So at the end of any of these years, we can pull back and say, no, we don't want to review, we don't want to continue with you, but then we have to go through the RFP process all over again. So it is a 1-year contract with every year we have to sign a renewal. But it covers 5 years. The RFP covers 5 years, but we do have the out in there.
Well, I think that's good. So, at the end of 1 year, I'm assuming that they have ways out to, let's say we went to a different company. We didn't choose Paramount. That way they would have it out after the year, because they made all these assumptions that we couldn't even demonstrate what
Yep.
Alrighty, any other comments, questions?
And I'm happy to share the RFP with this committee once it's done. We have the process where we have to send it to DPI, and it takes them 2 to 3 weeks to review it. Happy to bring it back to another meeting, that if you just, for your information, to want to review it and see what's all involved. It's
Friday update or.
Yep.
78 pages, just for the record.
Yeah, right.
we
You can
email it,
out,
exactly.
Put it on board docs.
Yeah, that could be a good Friday update thing instead, to email that out versus talking about it, because once we submit it to DPI, it's pretty much in their hands, and it
Right.
really is a template that guides what we do, so.
Alrighty. Thank you, Sherry. Other business. Are there any recommendations for future committee meetings? Anybody have anything? No? Well, if you do, email Darren or myself and we will get it agendized. Ready. Next up is an executive session that we are in desperate need of. Darren, right?
Hard, but
We're looking for a motion to go into executive session. Corey,
Sure. I'll move to adjourn to executive session pursuant to WIS Stat Section 19.85, Sub 1E, for deliberating or negotiating the purchasing of public properties, investing of public funds, or conducting other specified public business whenever competitive or bargaining reasons require a closed session. Oakdale offer to purchase, tax keys WAKC 1360198, WAKC 1377002, and WAKC 1377003.
is there a second?
I second
Mrs.
it.
Voigt? The roll call vote.
Mr. Como? Ms. Voigt?
Aye.
Mr. Montiel?
Aye.
Ms. Reinacek?
Aye.
And Mr. McCaffrey?
Aye.
Passes 5-0.
All righty.
It's okay with you, Mr. McCaffrey, I'll step out for this. If it looks like we're not going to get back into open session, can someone just give me a heads up so I can,
You want to say goodbye to us?
no,
Oh,
I'll do whatever you need. Okay. Brevity.
all righty.
We'll hear him go by. That's a-
Yeah, we'll see him squealing out.
Are you squealing?
We'll know he's gone. All right, thanks, Corey.